Well, it is 12:15 and we'll go ahead and get started. We want to welcome all of you to today's webinar with Dr. Adams from the Arkansas Department of Health. Today, we're going to be talking about addressing chronic disease through social determinants of health strategies. I just want to remind everyone that we are recording today's webinar. We will be sharing the recording and posting the recording to the ABIN webinar page, as well as today's PowerPoint slides. So I know oftentimes people want to get the slides and want to get the recording, so that will be listed and housed on the ABIN webpage for any of you to look at after today's presentation. And with that, I want to formally introduce Dr. Becky Adams. Dr. Adams is the Diabetes Section Chief and Partnership and Policy Director for the Chronic Disease Prevention and Control Branch at the Arkansas Department of Health. She has a Doctor in Public Health Leadership from UAMS, Faye Bozeman College of Public Health, and a Master's in Public Health from the University of North Carolina in Chapel Hill. She is a registered dietitian, nutritionist, and certified diabetes care and education specialist. She's held various leadership positions in the state and national associations. She's received the Association of the State and Territorial Public Health Nutrition Directors Award in 2013. She's also received a Excellence in Association Work Award, and in 2019, an Outstanding Leadership for the Obesity Prevention Nutrition Council. In 2018, she received the Arkansas Public Health Association Tom T. Ross Award. Her interests include primary prevention of chronic disease and lifestyle change through policy and environmental change to improve quality of life. I've had a few minutes to talk with Dr. Adams, and she said she finds a lot of energy from her work, and she's extremely passionate about this topic and about working in this space. So without further ado, I'm going to turn it over to you, Dr. Adams. And I know we talked about, she requested that if you have questions during the presentation, please type those in the chat, and we'll find a place to stop and ask those questions and give her an opportunity to respond. We'll also save about 10 minutes at the end for questions. So with that, we'll turn it over to you, Dr. Adams.
And Kim, it looks like we have a little technical difficulty. It looks like Dr. Adams dropped off the webinar. So I've texted her and now I'm going to give her a call.
Okay, perfect, Jenny. Thank you. I appreciate that. We'll give her just a minute or two to join. We know that this is the third of a three-part series. And so the first webinar, we were able to hear from our leader. We have an SDOH committee that has been meeting, I think it's been a couple of years now, and Justin Valines is chairing that. And so, Justin, thank you for your leadership. The first webinar in this series, we had Justin Valines from SHARE, and Josh Hall from HARC, and Rolinda McFadden from AFMC. And they talked to us about social determinants of health and really laid the groundwork and developed a framework for the series. Last month, Caitlin Johnson and myself talked about social determinants of health, as well as social determinants of mental health and the effect that social determinants of health have on our mental health. And now, today, for the third of this series, will be focused on chronic disease. And so we know it can be extremely challenging when we're trying to work with folks who might be struggling with chronic disease if they don't have all of the resources needed to access to help them with their health. So with that, we're excited for the last of these series. Don't know if anybody else has any updates or things they'd like to share about an upcoming conference or anything that might be happening around the social determinants of health space that we want our audience to know about. I see Justin coming off camera.
Hey, Kim. Yeah, and sorry about that with Becky having a little technical difficulty, but uh, it's exciting times to really kind of we know that social needs and social determinants of health is a precursor to outcomes overall with patient care. I know a lot of hospitals and clinics have part of their strategy. It's part of a lot of value-based programs that hospitals and clinics are striving to understand their community, understand their patients. And one of the key factors when working with persons with diabetes or congestive heart failure, et cetera, is, are they dealing with any social needs within their overall life? Is it, do they have food insecurity, a housing insecurity? Those are key elements to understand of what's going on with the patient or their family dynamic, which then can allow for interventions, resources to be given to that individual. So I think, oh, there's Becky. Hey, Becky. I think, but her presentation will kind of build upon our series to really, there is strategies to take, there is ways to be able to come together as a community, working with your community-based organizations along the way. So I'm sure Becky will talk about specific on chronic diseases because Arkansas, we deal with some, as a state. So thanks everyone for joining today. And I really want to do a shout out to our work group. They've been instrumental to our education for our state. One thing to look on the horizon in the next couple of months is really having Z codes and G codes on social determinants of health. So something to look on, maybe in August or September timeframe. So I'll turn it over to Dr. Adams.
Thank you. I apologize for the technical difficulties. I'm so glad that that it's working now. I want to thank the Arkansas Behavioral Health Integration Network and the Social Determinants of Health and Population Health Work Group for inviting me to share today. These are objectives, which I'm sure you've seen. I plan to provide some data related to social determinants of health and chronic disease. We'll explore evidence-based interventions, including a few we've implemented in Arkansas. I'll also share a few recommendations from several nationally recognized organizations. I really hope at the end of this webinar, you will have identified how you can help to address negative social determinants of health in healthcare, in your community, and to help individuals overcome existing social determinants of health. The CDC's National Center for Chronic Disease Prevention and Health Promotion's approach to social determinants of health and chronic disease include the built environment, community clinical linkages, food and nutrition security, social connectedness, and tobacco-free policies. And there's a lot of overlap across these these determinants. But today I'm going to focus on food and emphasis on nutrition security, built environment, and community clinical linkages. Excuse me. If you have questions or comments, you can put them in the chat, or you can come off mute during the presentation. I think we all have something to learn from each other, and I want to hear about your experiences as well. And we're going to start by looking at CDC's Social Vulnerability Index. This index indicates the relative vulnerability of counties in the U.S. This is a tool that helps stakeholders understand broad social context at a local level. It comprises 4 aggregated themes: They are socioeconomic status, household composition and disability, minority status and language, housing type, and transportation. Here I chose St. Francis County with the topic risk factors for diabetes and the indicator obesity. St. Francis County has an obesity rate of 40.5%. The SVI is almost 0.97, 9691. This makes St. Francis County in Arkansas more vulnerable than almost 97% of counties in the U.S. And we know that there is disparity between the Delta of Arkansas and Northwest Arkansas. And of course, we're talking about social determinants of health, and place matters when you're talking about risk for chronic disease. And the SVI for Benton County in Northwest Arkansas is approximately 27 compared to almost 97 in St. Francis County. But we can also drill down and look just at the state level. Again, I chose St. Francis County for this example. This time I chose the indicator physical inactivity. Over 34 adults reported being physically inactive. And St. Francis County is more vulnerable than almost 96% of Arkansas counties. I want you to notice the green dot at the top right, top right of your screen. This represents St. Francis County. The x-axis is the CVI, or the Social Vulnerability Index, and the y-axis in this case is physical inactivity. We'll look at another indicator because there are 15 indicators available in this tool. Another one that I chose is diagnosed diabetes, also in St. Francis County, and CVI. St. Francis County is represented by the green dot again. 12.6% of adults in the county reported a diagnosis of diabetes. So just a little bit of level setting and emphasis on context. Let's see. Okay. This infographic was borrowed from an open source document that was published on behalf of the American Heart Association. So it will refer to cardiovascular disease, but it could apply to other chronic diseases as well. I split it in two parts to improve readability on the screen. And we must consider context and lived experiences to improve chronic disease outcomes. And community input and engagement at all stages are necessary to develop and successfully implement interventions to improve chronic disease outcomes. These interventions that provide available, accessible, and affordable resources to vulnerable populations. Multiple levels of interventions at the policy, community, and individual levels are needed to address the socio-political, community, and lived experience context of cardiovascular disease and other chronic illnesses. And of course, one of the resources needed is healthy available foods. So we will talk about food and nutrition security. Food insecurity is limited, reliable access to enough high-quality food to not only avoid hunger, but also to stay healthy. Food deserts are areas with less access to grocery stores and other outlets that sell healthy, affordable foods. And I know that most of you, or if not all of you, are familiar with food deserts. Not sure about food swamps, though. Food swamps are areas with a high density of establishments that sell high-calorie fast food and junk food relative to healthier food. These areas are nutrient poor, they have more nutrient poor foods that are abundant and often highly marketed, cheap, and convenient to access. Now, information on how food insecurity is related to chronic disease. This chart is from a study that examined the relationship between high, marginal, low, and very low food security and 10 chronic illnesses: hypertension, coronary artery disease, hepatitis, stroke, cancer, asthma, diabetes, arthritis, COPD, and kidney disease. And adults in households with very low food security were 15.3 percentage points more likely to have any chronic illness. The number of chronic conditions for adults in households with low food security is on average 18% higher than for those in high food secure households. And adults in households with lower food security status have elevated probabilities of chronic disease diagnosis for each and all of the chronic disease examined. For instance, adults in very low food secure households are 10.5 percentage points more likely than in high food secure households to be diagnosed with hypertension. This chart shows that any level of food security can have influence on chronic diseases. You can see on the left hand that the light blue bars represent high food secure households, and as you move to the right and the darker blue, you move through marginal food security, low and very low food security. And again, you can see that all levels of food insecurity matter. Food security status is more strongly predictive of chronic illness in some cases than even income. Income was only significantly associated with 3 of the 10 chronic diseases: hepatitis, arthritis, and COPD, while food insecurity is significantly associated with all 10. So now we're going to talk about food deserts and food swamps. So in one cross-sectional study that included over 3,000 counties or county equivalents, those with the highest food swamp score had a 77% increased odds of high obesity-related cancer mortality. The authors and others suggest that policymakers, funding agencies, community stakeholders should implement sustainable approaches to combating obesity and cancer and establishing access to healthier foods, creating more walkable neighborhoods and community gardens, and many other evidence-based interventions. Another study by Cooksey Stour and colleagues support the position that food swamps are a separate phenomenon from food deserts and may play an even larger role than food deserts on community level obesity rates. Food and nutrition insecurity are predominantly influenced by local environments, including surrounding neighborhood infrastructure, accessibility, and affordability barriers. Healthy food accessibility and insecurity is a social determinant of health. And there's more attention right now regarding nutrition. I don't know, and you can drop this in the chat if you'd like to, but how many of you are familiar with the White House Conference on Hunger, Nutrition, and Health that was held in September of 2022? And I can't see the chat right now. So Jenny or Kim, can you tell me what's coming up on there? Are people expressing?
Sure. So there, people are extremely impressed with the tool that you're using, with the data that you're showing. We have a comment. It's incredible correlated data for social determinants of health gap with chronic care conditions. People are requesting your slides and this information. So lots of positive information coming in.
Well, that's wonderful to hear. Thank you. And I'm very happy to share the slides. And I really hope, because there's so much information and so much good work to do, that I really hope that I'll hear from some of you about, and I can share more information, and maybe we can become involved with some work together. I hope that will happen. So there are 5 pillars that came out of the Conference on Hunger and Nutrition and Health. Those are included in what is now the national strategy. So these pillars to end hunger and increase healthy eating and physical activity include improving food access and affordability. The goal of Pillar 1 is to end hunger by making it easier for everyone to access and afford food. This includes using federal and state programs, as well as policy and programs at the local level. Pillar 2, to integrate nutrition and health by prioritizing the role of nutrition and food security in overall health, including disease prevention and management, and ensuring our healthcare system addresses the nutrition needs of all people is of particular interest. Pillar 3 would foster environments that enable all people to easily make informed, healthy choices, to increase access to healthy food, encourage healthy workplace and school policies, and invest in public messaging and culturally appropriate education campaigns that resonate with specific communities to help reduce disparity. The national strategy also includes physical activity, making it easier for people to be more physically active, in part by ensuring that everyone has access to safe places to be active, and increasing awareness of the benefits of physical activity. And lastly, conducting research on and measuring physical activity. And lastly, nutrition and food security research is also included in the national strategy. We want to improve nutrition metrics, data collection and research to inform nutrition and food security policy, particularly on issues of equity, access, and disparities. And now for audience participation, we have a poll.
Dr. Adams, the interventions to overcome food insecurity poll?
Yes.
That one? Okay, I'm launching it. Everyone should be able to see it now.
Great. Hey, please take a few seconds to answer this poll.
All right, we're getting there. About 50 people have responded. I'll give it another 5 seconds or so. All right, we're at almost 60, so I'm going to end the poll and share the results.
All right.
So
I'm
are
sorry,
you
Jenny.
able to see that? Are you able to see the results?
I am. Thank you. Yes. And how many of, okay, so first of all, I'm looking at, okay, so a good number of you picked all of the above, and then quite a few picked A, B, and C, which is not surprising at all because it doesn't seem like street scale or community scale design and land use policies would have anything or much to do with overcoming food insecurity. But in fact, where you place food or where you place farmers markets, where you place grocery stores in relationship to where people live or work, where you know, transportation to these opportunities for food are very important. So public transportation in some cases. So actually, the built environment and transportation, walking, land use is also related to food security. Okay. And let's see if I can. Oh, all right. So was anybody surprised by that? And I still I can't see the chat. So
We'd love it if you could put a comment in the chat if you were surprised, or any comments about the poll question. Makes sense. Thank you, Dr. Adams. It definitely does make sense.
well, now we're going to explore a few evidence-based interventions that address the first four pillars. And community and school gardens can provide access to affordable, healthy foods. Shared use agreements between schools and municipalities allow for school facilities such as the track, the gym, the school garden to be open to the community when school's not in session. One community garden I want to mention was located near a senior center, and the seniors tended the garden alongside students, and the seniors were able to use the produce. There are lots of examples of community and school gardens in Arkansas. So if you're interested in more information, if you'd like to get involved with building a community or school garden in your community, have lessons learned, anything like that, I'm so happy to talk with you. Other interventions like farmers markets, this is not a surprise, can bring healthy food to a community. So it's also important how we design our interventions, and particularly in the built environment. Notice that this bench is located under a tree with wonderful shade. And why do we want to have consider things like this? If you think about someone maybe that's older or just can't stay on their feet for a long time, they may not have the opportunity to participate in farmers markets or other community events without a place to sit and rest. So there are lots of things that we need to consider, and we've got to hear from the community members, not just those that participate, but also the potential participants that may not be showing up yet, so that we can make sure that our interventions are designed to meet the needs of everyone in the community. This is an example of a couple of other farmers markets. And some markets accept SNAP benefits. And this is important in order to reach people who otherwise wouldn't have access to healthy, fresh produce in some areas. I don't know if you're familiar with Double Up Food Bucks. We do have a grant in Arkansas that allows us to implement this national program. But Double Up Food Bucks allows SNAP recipients to use their benefits and basically double the benefit for fruits and vegetables. So for instance, if you have $10 in SNAP benefits and you're purchasing fruits and vegetables at an establishment that does participate in the program, then you actually get the opportunity for $20 worth of produce. So this is an incentive and an assistance to help people who are on SNAP to choose fruits and vegetables, produce.
We did have a question about that, Dr. Adams. which is, do you know if SNAP benefits if the farmer's market will allow you to use SNAP benefits to purchase plants for gardens?
What the recipients can purchase is a SNAP rule, not a farmer's market rule. I'm not familiar enough with the SNAP rules, but I really don't have that answer, but I am happy to find out. If you want to reach out to me after, give me a couple of days and I will get that answer.
Wonderful.
Well, by
Okay.
the way, Double Up Food Bucks is also offered through some grocery stores because not all communities, of course, have farmers markets. We would love to scale this program. You know, the funds are limited and there are a lot more people who would be eligible, a lot more farmers markets and grocery stores who would be interested than what we can support right now.
Wonderful. And Justin was able to put in the chat a list of things, eligible items to purchase with SNAP benefits and things that are not eligible. So thank you, Justin. We appreciate that. We also had a question a minute ago when you got the information from the White House conference on this. Was there any information about grant opportunities?
You know what? If you drill down into the documents that came out of the conference and the strategy, they do. There are some things that are available. So depending on what kind of grant opportunities you're looking for, I can maybe help to point you to some of those. I'm very happy to do that. If I don't know of opportunities, I can also reach out to some of my colleagues who are up on that a little bit more than I am.
Okay, wonderful. Thank you for answering all these questions.
Oh, I'm happy to do it. I want to hear from you guys. And Justin, thank you. You just demonstrated something I am going to talk about quite a bit, and that is partnership and collaboration, teamwork. Thank you. Okay, let's see. Another intervention that can provide food assistance that is tailored to meet the needs of people with certain illnesses is food as medicine. So it's time for another poll around food as medicine. Thank you, Jenny.
Sure thing. They're coming in. Oh, it's getting faster now.
This one's a little bit easier.
We have passed 50% of people responding. And you ready for me to share the results?
Yes, please.
Okay. Here we go.
Great, thank you. Well, this is wonderful. Since we have some folks on the Zoom that have some experience, have seen this implemented, or maybe you're somewhat familiar, you may have questions for each other. So if there's anyone that wants to share, and you're welcome to come off mute too, but if there's anybody that wants to share what they've seen or anything that you've heard about that you have particular interest in, that would be great to share right now. If not, we'll move on.
Hey, Becky, this is Justin. I know that UMS and the Arkansas Rural Health Partnership, and I think with ADH's help too, in some capacity, is doing a food as medicine in the Delta region, and actually doing, if my understanding, what I've read, doing a little research specific on diabetics, and offering them 3 balanced meals over a period of time and then tracking that individual and their overall health outcomes. Um, and I think just some data that I looked at that was they are making a difference. That's just one initiative that I've seen and read about on specific for diabetic patients.
Thank you, Justin. Okay, well, I'll share just a little bit, and then for the sake of time, we can get more information after the webinar. Okay.
Justin, can you put that program information in the chat for us? Do you
Sure.
mind?
I will put it in the chat.
Thank you.
And Dr. Adams, you asked for a 10-minute heads up. We are, oh wait, this goes to 12:15. Never mind. Sorry.
That's okay. We'll move on a little bit faster, and then again, the things we can't dive into, I'm happy to follow up. Okay, so food is medicine, just a little bit. The national strategy under Pillar 2 and several other national organizations argue for the integration of specific food and nutrition interventions in or closely coordinated with the healthcare system. And in this, we talked about one being food is medicine. This intervention includes medically tailored meals sometimes, or it might be medically tailored groceries or produce prescriptions. So there are various ways that this might look. They're typically directed by clinicians through the healthcare system. They're typically provided at no cost or very low cost to the patient and funded by healthcare, government, or philanthropy. The Biden administration issued a challenge to organizations and agencies to address the pillars in the national strategy. And the Rockefeller Foundation and American Heart Association mobilized $250 million to build a national food as medicine research initiative. Not sure exactly where they are in that process, but this initiative will generate the tools and definitive evidence necessary to help the health sector design and scale food as medicine programs to improve both health and health equity and reduce overall healthcare costs. So we're going to switch now to the built environment. It's been said that what we build now will give us an environment that we are either blessed with or stuck with over the next 30 to 50 years. And I think if you can look at the way our built environment has developed with automobiles, and I mean, I can't go into all the different things that have impacted the way our built environment looks right now. But we do need improvements to the built environment. We need community programs, some of which we're going to talk about in a few minutes. And we need policies like complete street policies that benefit all users, whether you're walking or rolling or biking or driving an automobile. These streets should be available for all of these users. And physical activity is highly associated with chronic disease, thus significantly reducing quality of life and rising healthcare costs, physical inactivity, that is. So the odds of physically inactive adults who report having a diagnosis of diabetes were 133% higher compared to physically active adults. For hypertension, it was 52% higher. And the odds of physically inactive adults who report having coronary heart disease were 83% higher compared to physically active adults. Various sectors, including the healthcare sector, can work in partnership with other sectors to improve physical activity. Strategies such as counseling, social support programs, and campaigns can help to promote or complement the Community Preventative Services Task Force recommendations for effective built environment interventions, which I hope to be able to mention in a few minutes if we have time. So some examples of built environment interventions that have been successful include, well, I'll let you read these, but in addition to increasing access to opportunities for physical activity, which is something I really care about, and active transportation, there are often other benefits that may have been brought about by these interventions. So let's take another poll.
I think I launched the right one. The
Yes, it
community
is.
tab.
Yes.
All right. All right, we have passed 50%. We're coming up on 30 seconds and gonna stop the poll.
Thank you, Jenny. You want to share
Sure.
the results? Okay,
Okay.
there we go. Okay, yes. All of these are benefits of these type of physical activity interventions. If you think about things like reducing crime, economic development, that might not come to mind immediately, we have had teams, collaboration across economic development, sustainability, housing, health, I know transportation, all of these groups coming together because let's think of an example. If you are for health, I would like to see sidewalks, right? Maybe we have sidewalks that are wide enough downtown for someone in a wheelchair pushing a stroller could use the sidewalk. What if the curb cuts allowed for someone in a wheelchair to come off the sidewalk without going into the middle of the street, right? So we want them to be safe. For health, they can help increase physical activity. For economic development, you have people walking by stores, they're more likely to purchase things to go into the stores if they're walking by than if they're driving by at 40 miles an hour on a county road or something that goes through town. And you can do something about that with street road diets and things like that. But and then, if there are eyes on the road, if people are out and about, that does reduce crime. And let's say we put lighting up, and because we know that can help encourage people to use the sidewalks. Well, that also helps to deter crime. And then improving green spaces. What if our sidewalk, or we had a trail that went from places where people live or work or downtown and shop to parks, or maybe from the school to the park. So there are a lot of people that are invested or have benefit in these kinds of interventions. Yeah. Okay. So sustainable communities are communities that implement these types of interventions. And I wanted to share this. This is an accessible playground. This child, you can't really see, but you would not believe the smile on his face. He's able to swing because because we have an accessible playground equipment. He can get to the equipment because the ground cover allows for the wheelchair. So we want to make sure that when we're building these things, we're building it for all users. We have done a lot of walk audits in Arkansas. We've trained the trainer for walk audits, and I'm going to talk a little bit about a program that we're doing now that can help us expand this. And I wonder if anyone has participated in maybe a local planning meeting, walk audit, anything like that. I know we don't have them out, in a lot of places, but we are trying to scale that because we can make a real difference with this. We need community members involved. We need decision makers out on those walk audits with us. We need people in wheelchairs pushing strollers. We need funders, community members that can tell us what is important to them, what they notice we might not, and all ages also. So anyway, those are the people that we pull together when we do local walk audits. And the walk audits are designed to help us redesign our streets. Another group, this group does have a variety of different types of community members. So I'm excited to tell you about this next program that we have been involved with for a couple of years, and it has the capacity to result in walkability action plans in communities across the state, maybe 6 to 10 communities per year. And this is the it's the Arkansas Walking College now. A couple of years ago with our arthritis grant, we engaged America Walks to deliver its National Walking College program here in Arkansas. And this program is an online educational program for walkable community advocates whose goal is to build capacity of local change agents to increase walking and improve walkability in their communities. So this is just shows you, you can see where we were doing the walk audit. We use the AARP walk audit toolkit. There are others, and you can see on the right-hand corner of your screen, you can see a couple of people during the walk audit, and we held an in-person workshop the last week of the college. So if you're interested, we are going to be recruiting for fellows in the coming months to start in January. But we are being trained to run this college as an Arkansas Walking College with just minor assistance from America Walks, so that we are sustainable. And we are partnering with Cooperative Extension, and they're going to manage the Arkansas Walking College. And our diabetes program is actually helping to fund the program. Okay, this is a little bit different type of intervention, but it's a successful policy interventions that I wanted to mention. Better Beginnings is designed to improve childcare environments, to support to support child health and development. Implementing knapsack into Better Beginnings can improve the quality of childcare programs and ensure more children grow up healthy in Arkansas. knapsack is an evidence-based, trusted strategy enabling childcare centers to attain best practices regarding nutrition, active play, and screen time. On this slide, you can see how nutrition and physical activity requirements are included in the Better Beginnings Quality Rating Improvement System. And if you have any questions about this, I'm happy to answer questions later. But collaboration is key. In 2016, the Community Preventative Services Task Force recommended combined built environment approaches to increase physical activity. This is an update from their 2004 recommendations for land use and street scale interventions. These combined built environment approaches work to create or modify environmental characteristics in a community to make physical activity easier and more accessible. We all can participate in efforts to improve policy system and environments and be advocates for change in our communities. And now community clinical linkages. Each sector brings unique strengths, resources, and expertise and areas of influence. So it's important that we work together. In a few minutes, we're going to look at a few examples of evidence-based interventions that involve community clinical linkages. Some organizations' food insecurity interventions are part of a more holistic program that connect patients to resources for assistance not only with food security, but also with housing, transportation, utilities. I could go on and on. A better understanding of the broader social needs of communities can help us to target and tailor food security interventions and interventions that address other social determinants of health. There are resources. Can't mention them all. I'll mention a couple, but there are resources. I'm happy to try to connect you with some of those. But there's a publication from the Applied Research and Evaluation Branch of the Division of Heart Disease and Stroke at CDC, Heart Disease and Stroke Prevention, I should say, at CDC. And this is a resource called Community Clinical Linkages for the Prevention and Control of Chronic Diseases, a Practitioner's Guide. Also, there's guidance for hospitals interested in assessing food systems and food security in their community health nutrition, sorry, I'm so used to nutrition. Community health needs assessments. This is called Making Food Systems Part of Your Community Health Needs Assessment. It's available through PHI, and it is a result of the Tackling Hunger Project. The guidance outlines key food insecurity indicators, data sources, and measurement tools, and food security and food system stakeholders. So there are lots of other examples of resources.
And Dr. Adams, we have about 8 minutes left.
Okay, thank you. Thank you. Okay, so I'm just going to show a few examples of successful community and clinical linkage interventions. I want to emphasize local health action teams because they can promote health awareness and opportunities to improve these connections across communities. And I've already talked quite a bit about the importance of hearing from your community, but this is a way to get people involved in moving progress forward. I want to mention two CHWs because Arkansas has recently adopted a voluntary certification program for CHWs. And if you're interested in knowing more about what CHWs can do, I would love to talk with you. So I am not going to talk a lot about these interventions, but if you are interested in being part of a group to address these, let me know. I'll try to connect you. There are groups, including our social determinants of health and population health work group that are working to identify successful and relevant interventions. Also, I just want to mention that there are several organizations that have recommendations or frameworks. A lot of them have common themes. For instance, the National Academies of Sciences, Engineering, and Medicine framework includes awareness, adjustment, connecting, enabling, and promoting. The American Heart Association, you can see here, I'm not going to read it to you, but you can see just looking at these two that things like screening and referral, of course, and addressing social determinants upstream. We talked about nutrition and physical activity, social determinants. There are others: poverty, education, and healthcare, access and coverage. But addressing those upstream, assessing, maybe using your community health needs assessment, incorporating social determinants of health into that assessment. We want to assess at the individual level and at the community level and identify those resource gaps and bring in partners that can help us to increase those resources and scale them, actually. Okay. One of the strategies is to use behavioral lifestyle programs, social support programs, and I'm going to mention the National Diabetes Prevention Program, which can help participants. Not only is it very effective and cost effective for reducing risk of type 2 diabetes, but it also can help participants overcome social determinants of health or health-related social needs. Addressing those social needs can support participant success in these programs, but also these programs can help to participants to overcome social determinants of health that they are living with. These programs are designed to help assist with identification of health-related social needs and referral. And they learn, the participants learn tools and skills that can help them overcome these social needs or challenges. So I've highlighted DPP here, but diabetes self-management education programs can do similar things, but they're for adults with diabetes, where DPP is for people at risk for diabetes, so with prediabetes. There's also something that I'm very interested in learning a lot more about and helping to implement, and that is family healthy weight programs. These are programs somewhat similar to the DPP program, but they're for children with overweight or obesity. And this is an evidence-based program that is being promoted and supported by lots of organizations, including the CDC. So I want to take a quick poll here, and we're only going to have 30 seconds to answer this poll because I want to move forward just a little bit.
Wow, people are moving fast. We're already at 45%. We're at 50%.
That's
all right.
awesome. And we only have a couple of minutes.
There we go. The results should be on your screen now.
Okay, yes, great. All right. So some of you do refer patients to DPP if you're interested in learning more. We actually have an online version that that patients can access for free if you're in an area that doesn't have a DPP program located there. Okay. And moving on, we're getting toward the end. I love this picture. This is the Yellville Spring Fling several years ago, but it just kind of reminds me of a community where there's a sense of belonging. And I want to leave you with these thoughts. What if your community had access to healthy food options? And maybe not so many unhealthy food options that are right in front of you all the time. What if you could ride your bike or walk to a farmer's market? What if your community had access to green spaces, places for your children, your pets, the elderly? What if your community had affordable housing, located within walking distance of healthcare and entertainment. And I would suggest employment and food and physical activity opportunities. What if your community provided a sense of belonging? What if you knew your neighbors like family? What if your community was a livable community? Wouldn't it be wonderful if all of our communities were livable communities? Questions?
We did have a question in the chat. Justin posted a list of hiking trails for people who needed wheelchair access. And we had a question, does anyone know of parks throughout Arkansas that might be accessible for children with special needs? Just wanted to ask if anyone knew about that.
I was asking that question because I'm working in Power and we have a lot of kids and kids on the waiver. So I just wondered if there was a list like Justin posted for those trails of handicap accessible parks throughout the state.
You know, I don't know how many are included, but I do know that Arkansas Disability and Health Program is one of our partners. We've been working with them for years. They're wonderful. And they partnered with the Boy Scouts and had those little, what are those go something cameras? I'm really technological. But they had those cameras and they went and actually filmed trails and parks and you could actually, someone who needed to know you know, how accessible that a park or a trail might be for them could actually see the video and determine for themselves whether that was appropriate for them. But I think our best bet would be the Arkansas Disability and Health Program, and I'm happy to connect you with them. If I don't know if anybody else has information that I don't.
Yes, ma'am, that would be great. And a lot of people are putting that parks in the chat. Thank you.
Oh, great.
This is fantastic. Thank you, guys. And yeah, before you leave, you may want to just take a quick look at the chat. People have been putting in different programs that are relevant to areas that you've been talking about. We've got trails in here. We've got parks. We've got examples of food programs, SNAP benefits, all of those things. So fantastic job. Thank you all for sharing your expertise and your resources. As Dr. Adams said, collaboration and partnership is so important.
And Kim, can you all capture the notes in the chat to share?
Yes,
Great.
we can.
I'm going to stop sharing my screen now, and thank you all for spending this time with me today.
And thank you, Dr. Adams, for sharing your expertise with us. It's been a fantastic presentation. I hope everyone has a wonderful Hope everyone has a wonderful afternoon, and just want to remind you that the ABIN, we will be having an ABIN webinar in July, the second Thursday of July from 8 a.m. to 9 a.m. And this month we have a speaker from Mayo Clinic who will be speaking about integrated behavioral health. So we hope to see you then, and we hope you have a wonderful afternoon.